All right. Thanks so much. My name is Mitchell Lunn. I'm from the University of California, San Francisco, where I'm a clinical research fellow and one of the PIs of PRIDEnet and one of the co-directors of the PRIDE study, which I'll share with you a bit today. We're really excited to be here and to be partnering with pSCANNER. Just out of the interest of full disclosure, there is a company in LA that provided pro bono mobile app development, which I'll talk about today. And I usually start all my presentations with a little bit about who I am. And so I'm a gay cisgendered man, that is somebody who's not transgender, and I typically use traditional male pronouns like he, him, and his. And you'll see why this becomes important a little bit later. And the population that we deal with and that I wanted to share a little bit with you is yet another acronym. There's many that have been shared today that are new to me, but this one is sexual and gender minorities, which is, I think most people have probably heard of LGBT or lesbian, gay, bisexual, and transgender. This is a larger umbrella term that includes anybody who is not heterosexual and who is not cisgender, and that's the population that both PRIDEnet and the PRIDE study focus on. And so PRIDEnet is one of the, we're using the term participant-powered research network rather than patient-powered research network because we are disease agnostic, but rather population focused, devoted to engaging sexual and gender minorities in the research process from end to end. And as Lucilla and others have talked about today, we hope to bring diversity both to pSCANNER and to PCORI. We are a very diverse group, obviously in terms of sexual orientation and gender identity, but also we're made up of heterogeneous communities that are diverse in race and ethnicity, in the geographies that they live in their ages and their religions. And we're currently a network of 45 different organizations from across the country. Those organizations range in size and scope, but can really be divided in largely into three categories, which are LGBT-focused health clinics, many of which are federally qualified health centers. Those include organizations like Callan Lord in New York, Howard Brown in Chicago, and Lyon Martin, for example, in San Francisco, which primarily serves lesbian, bisexual women and transgender women. Additionally, the other category is large LGBT-focused community centers, such as the San Francisco LGBT Community Center, Seven Rivers in La Crosse, Wisconsin, and the Gay and Lesbian Community Center of the Ozarks in Springfield, Missouri. And then the third category are large service and advocacy organizations, such as the Human Rights Campaign. Many people recognize this as a symbol of equality that's been on many bumper stickers you've, I'm sure, seen around. Additionally, organizations like the Gay and Lesbian Medical Association, the World Professional Association for Transgender Health, and Services and Advocacy for GLBT Elders. And so these are organizations that we're partnering with a variety of engagements that can be from recruiting participants to having them engaged in our governance to disseminating research results. And so I wanted to talk a little bit about why PRIDEnet is needed, and that's that sexual and gender minorities are an underserved population, they're understudied, and they're vulnerable to poor health. And that really dates back at least, if not further, but to a longstanding history of discrimination and stigma, such that homosexuality was a pathology until the early 70s. It was a psychiatric diagnosis until it was removed from the DSM in their third version. And since then, at the time of genetic sequencing, there was a hunt for the gay gene in an attempt to fix or repair a quote-unquote mutation. And conversion therapy continues to be a large threat in many states in this country, as it's only really outlawed in 3 states in the United States. Of course, in the 80s and 90s, the HIV epidemic led to a cry for help from the LGBT community that was largely neglected by government and by medical research. And today there exists persistent discrimination. All of the light tan colored states are states that you can still be fired for being LGBT or T in this country, 29 of them. Several states, Arkansas and Tennessee, have specific laws prohibiting the development of non-discrimination laws for sexual orientation. And we know that when patients go to the doctor, they're met with providers that are actually undertrained. This is a study that we did in 2011, looking at how much LGBT content is done in medical schools, and about 5 hours of content is devoted to the topic. To put it into perspective, there's about 1,600 hours during the first 2 years of medical school. And we know from a survey of about 5,000 people who are LGBT that about 50% of lesbian, gay, and bisexual people and nearly 90% of transgender people feel that there are not enough healthcare professionals adequately trained to care for them. So every time they go to the doctor, they're ending up having to educate their own physician and subsequently never coming back to the doctor. Because of this, and because providers don't ask about sexual orientation and gender identity, there are a large number of LGBT health disparities. Include that LGBT people smoke about 2/3 more than the straight population, 1 in 3, compared to 1 in 5. 41% of transgender people have attempted suicide in their life, compared to 1.6% of the general population. And of the homeless youth in this country, 40% of them are LGB or T. And largely this remains because there is invisibility of sexual and gender minority status in data. We are not recorded at all in the census. There has been no recording of sexual and gender minority status in Framingham or in NHANES, and in occasional study of questions in the Nurses' Health Study. I put an asterisk next to the National Health Interview Survey because for the first time in 2013, sexual orientation was collected in a nationally representative sample, and so it's beginning to be a little more visible. In 2010, actually, the National Institutes of Health requested to the Institute of Medicine to conduct a report on the health of LGBT people in an attempt to establish a research agenda. And this is a quote that we give all the time, which is that the relative lack of population-based data presents the greatest challenge to describing the health status and health-related needs of LGBT people in this country. And that, I think, is something that is spoke, very loud to us. And so with that, I'd like to tell you a little bit about the PRIDE study, which is really the research arm of PRIDEnet. The PRIDE study, because it's good to have an important acronym, is population research in identity and disparities for equality, with the overarching question of how does being a sexual or gender minority influence your physical, mental, and social health. Briefly, this is a national study that is online. It's a prospective, longitudinal, and dynamic that is continually enrolling cohort study for people who are adults that live in the United States and are a sexual or gender minority. We are recruiting through a variety of ways because it's electronic. We're recruiting through electronic means, including social media, LGBT-focused apps, and online advertisements, through community-based organizations, such as the ones I mentioned in PRIDEnet, and healthcare providers. The one to add to this list, as we'll discuss at the end, is hopefully pSCANNER. We have a study that is in 2 phases. Phase 1 is a community listening phase, which began 3 months ago, in which we're gathering the LGBT community's health priorities and research questions to study before longitudinal data collection begins at the end of the first quarter of 2016. We have 5 guiding principles. One is that the study participation is low burden, that participants know best, or that participants are indeed our true north, as we heard from Marianne this morning, that we give back to the sexual and gender minority community, that we're easily accessible, and that participants are engaged in the process from beginning to end, that is, from research design, question design, to study design, to participation, to analysis and dissemination. And in order to do this, we developed a iPhone app that we released just over 3 months ago, with the primary priority of gathering these research priorities, but it's also a way for us to start creating this cohort to gather some demographics and to test the app physical activity functionality. So iPhones, of course, measure people's steps, distance traveled, and flights climbed daily, and we're collecting all of that data. So as of a couple days ago, we've had about 38,000 people that have had some sort of contact with our network in the past 3 months. 30,000 people have downloaded the app, and as of a few minutes ago, 14,925 people have completed their informed consent and have provided some sort of data. There's a dashboard where people can see stuff in live in real time, which I'm happy to show anybody later. Additionally, the community forum is the large part where people are nominating their research questions. There are, in these past 3 months, have been over 3,000 conversations that have been started, with about 4,500 replies to those different threads. And people can vote them up or down if anybody's used Reddit before, kind of similar to that. And over 40,000 votes have been cast. So we have the challenge of figuring out how to analyze that data soon. The app is just one way to participate. We have a web-based portal that's under development. We will also do traditional methods like telephone and paper if we need to, and do that in a multilingual way to make sure we're being welcoming to everybody. The web-based system has some other components, including, since we're an electronic study, if the email isn't getting delivered, it's like we don't exist at all. So having a high reliability of email deliverability is critical. We're using text messaging and automated phone calls through an integration with Twilio. Surveys are being administered through Qualtrics, and we're verifying people's address in real time, just like when you order something from Amazon, but with that also comes census tract data and geocoding at the time of enrollment. And so the question is how are people from PCORINET and the CDRNs actually going to reach the PRIDE study? And that brings up the big question of what is our computable phenotype? And this is really a challenging component as to how do we identify sexual and gender minorities in the EHR. ICD-10 has codes that are diagnosis codes for sexual orientation and gender identity minorities, but that's problematic because I think most of us don't view our sexual orientation or gender identity as a pathology. There is EHR fields at UC Davis where this is being collected in specific fields in EPIC, both sexual orientation and gender identity. And there are new proposed rules under future meaningful use to collect this data, and there are SNOMED CT terms for each of these. And of course, natural language processing to go through the free text of many of these. There is also word that the VA in not too distant future will be collecting sexual orientation and gender identity system-wide. And so with that, I would like to close with one quote, which is that we need to match our courage with rigor, our risks with results. It's what our mission demands and what the LGBT community deserves. There are many, many people that are involved in this, notably Juno Obeden-Maliver, who's the co-director of the PRIDE study, and Ruth McFarland, who's the co-PI of PRIDEnet with me. And with that, feel free to email us or visit our website. Additionally, I've put these postcards at the registration desk at the front, just a little bit about the app that you can take to your friends. Thank you very much.
How do you see PCORINET responding to data needs for the CDM that's out there now, 2.0, and going to 3.0 soon?
Yeah, so I think especially for 3.0, even looking at that version, that there's no collection of sexual orientation at all, and gender is, I believe, recorded actually as sex, with listed as men, 1, 2, or 3, 1 being female, 2 being male, and 3 being other. Sex in this country is actually a thing that is assigned at birth by the OBGYN or by the pediatrician as male or female, and that's the only option for it to be on a birth certificate. So other doesn't make complete sense there. There's no gender identity section, so we put in our proposal to PCORI and have had continued conversations with them that the CDM really needs to be modified. And I think if places like the VA are changing it, and if it goes into meaningful use, that those are large drivers to start including this data in a kind of more unified, standardized, and hopefully harmonized way.
Hi, thank you for the presentation. It was fascinating, especially with the number of participants for the app. So what do you think is the secret in being able to recruit so many people in such a short time?
Yeah, I think our secret was that we were on the front page of the San Francisco Chronicle due to good PR from UCSF and from Apple. This is a research kit powered app, which Apple announced in March. We were the sixth. They announced 5 apps at that time. We were the 6th app that came out. I think they pitched our announcement to multiple of their PR agencies because I think they wanted to show continued momentum for ResearchKit. And UCSF also has good relationships with their people. So we were, on NPR, on the front page of the San Francisco Chronicle, got pushed to the Washington Post, and we were had a BuzzFeed article, which gets 50 million views a month, right? So I think that, and we were 2 days before the Supreme Court announcement also, so it was kind of like a hot time for LGBT people, which was great. So, but when we look at where people are from, they're actually from all over the country. It's not just a San Francisco-focused place. They're actually from all 50 states. I don't have exact numbers. There is definitely West Coast-focused and California-focused, but I think we were the victim of a couple things of good timing. But I think also this is a community that's been discriminated against for so long by medicine that they felt that that this was a study that was for LGBT people and designed by LGBT people, that we are a group that they can trust, that they can share this with, and that they can make 3,000 posts in 3 months on a discussion board of things that are important in their lives from a health standpoint. And so I think all those things are what's been pushing.
If you don't mind, can I ask a follow-up question?
Sure.
So, I don't know the details of what other functions there are in the app, but if you were to recruit from people from apps or these other social media websites, that's sort of different from the more traditional ways of recruiting in clinical trials. So how do you feel about the sort of patient characteristics or the participant characteristics that are different from?
Yeah, I think, our characteristics are completely different. We have about 14% Hispanic, which is not so bad in terms of a representation of the country, but we're 86, I believe, when I checked earlier today, % white, right? Which is, largely not representative. So I think we're collecting a very convenient sample of people that can afford an iPhone and then have it. And that is a known weakness. I think when you're the first cohort study of LGBT people that's designed to be longitudinal and hopefully last for decades, I think we're allowed to do that in a way, and that we can do that first and then realize, we don't actually have any transgender people of color who live in rural areas, and we need to get some partners in our PRIDEnet in the PPRN component, and to figure out what is the best way for us to reach those people, and how are we going to do that, and how can we partner with those people on the ground to start doing that and making participation in this study a meaningful way. And that's why we're also having the web-based option to participate, paper and telephone, so that it's not just an iPhone app only. The interesting part is that if you do look at people's reported annual income and the histogram with each bin of $10,000 ranging from $0 to $100,000, the histogram is square. So we're not getting people that are skewed towards really high incomes. And so that was the one thing that was surprising for us. I think part of that also is that we do have a likely younger population, and younger people usually make less money. So I think they're bringing up that tail on the left side up to make that histogram rather flat.
Is there plans? I know it's an Apple thing, but is there plans to port to Android?
So the question is, was there plans to create an Android app? And the answer is not right now, because the web-based version will be completely responsive to any device. So as long as it's a internet-enabled device, you should be able to view it on any, which is what we're hoping for. I can talk more about the rationale behind ResearchKit after. Okay, thank you.